All right. Good afternoon, everybody. My name is Tim McMahon. I'm the Director of Marketing here at St. Joseph Hospital in Nashua, New Hampshire. And today, for our Facebook Live, I am joined by Dr. Akash from InCare Pulmonary and Sleep Specialists, who also have an office right here at the hospital. So with Dr. Akash, I'm going to give him a second to introduce himself as well. But the conversation today is all around lung cancer and lung cancer screening. And we have a bunch of questions that we'll be asking Dr. Akash. But if you have any questions throughout the broadcast, please post them in the comment section below, and we will see those as they come through and be able to answer them on the spot. And of course, if we don't get to your questions, we will certainly respond to them at a later point. So to start things off, Dr. Akash, can you please give us just a quick bio, who you are, a little more about InCare Pulmonary, and today's topic?
Oh, thank you for the invitation. My name is Ghazwan Akash. I'm a pulmonary and critical care physician with InCare Pulmonary. I also have a special interest and fellowship training in interventional pulmonology, where we focus on advanced bronchoscopy and special procedures. InCare Pulmonology also have multiple pulmonary critical care providers that are specialized either in sleep medicine, interventional pulmonology, and critical care medicine. We all work as a group, and we kind of collaborate among each other to cover different hospitals.
Great, thank you. So like I said, today's topic is all about lung cancer and lung cancer screening, and also some of the tools we now have to kind of at least assess and stage lung cancer for our patients. So like I said, we have a few questions we're going to start with, but again, if you have questions throughout the broadcast, please feel free to put them in the chat room and the chat box below. So one of the first questions we often hear from patients is, at what age is a lung cancer screening recommended?
So typically we focus on patients between the age of 55 to 75, and recently that age span has been expanded by Medicare and CMS services to up to age 80. We focus on people with extensive history of tobacco use or people who continue to smoke tobacco. Also, we focus on people with strong family history of lung cancer. Those usually get what we call low-dose radiation CT scan of the chest. It's non-contrast, so no injection is involved with the scan. It takes about 5 minutes to do the scan. Specific radiologists look up at those images, and the recommendation is to get those scans on an annual basis.
Okay, so once you start getting scanned, once you start getting the screenings, we're looking to do it every year.
Correct.
And starting at age 55, just to
Yes.
recap,
Yep.
up to age 80.
Correct.
Now, so if you start at age 55, and let's just say every year you're good, you're negative, is there a point when you can stop doing them, or kind of how does that work?
Well, I mean, if you fit into the category of high risk as defined by the number of pack of cigarettes you've smoked in the past, or if you're still a current smoker, the recommendation is to continue on an annual basis.
Okay.
The main reason for that is lung cancer can start at any age, and it's high probability of diagnosing lung cancer in those high risk group.
Okay. Yeah, we often compare it to things like colon cancer screenings, which can be every 10 years. So this is an annual screening. That's really good to know.
Yeah.
Now, you mentioned people with a family history of cancer, but for someone who has no family history, who doesn't smoke, should they still be screened for lung cancer?
Yeah, that's a good question. We don't know how the studies and recommendation will head to in the future, but as of now, this is the high risk group that is targeted. We all know that up to 20% of females who never smoke can get lung cancer, and we know up to 10% of males who never smoke can get lung cancer. So there could be future recommendation to cover, those groups.
Sure.
Especially if they have, family history or if they fit certain criteria. But as of now, this is the approved age group.
Now, so aside from age, family history, and history of smoking, are there other risk factors you often look at?
Yeah, absolutely. There is a lot of environmental risk factors. There is radon exposure. There's people who work as, you know, by profession, they have exposure, secondhand exposure to tobacco, firefighters, mine workers, and um, so those are at, an increased risk for secondhand exposure. There is a material that used to be used in construction called asbestos,
Yep.
which we no longer use. People who were exposed to that material and have history of smoking are definitely at a very high risk of developing lung cancer.
Okay.
So there is something like occupational exposure.
Sure, absolutely. Now, we just had a question come in through our audience, someone watching this presentation, and they want to know, does insurance normally cover screenings annually?
Yes, I mean, Medicare does cover it if you fit into that age group and the specific risk factor criterias, which is the number of pack per year that you smoked or you continue to smoke.
Okay,
Yes, it is covered.
that's good. And and we'll probably hit this again later, but if I have any concerns, if I'm someone, let's just say I'm not within that age range, but I am around secondhand smoke quite often, or I'm just generally concerned for whatever reason that lung cancer might be something I should be concerned about. Um, what's my best next step? Is it do I call your office? Do I call my primary care office?
I mean, there is always those concerns from people. I get that question a lot of time. Somebody who like recently witnessed a family member dying from lung
Sure.
cancer, and they are very concerned about their health and they want to be screened. Um, as of now, as I said, in terms of the age group, you have to be strict with the age group.
Yep.
But there's always other factors. Like, as I said, the occupational exposure, the family history. Some people who were discovered to have, for example, a little bit of high radon concentration in their homes. You can always have a reason to do the scan, at least in the beginning.
Yep.
One thing before you proceed to that scan is that any procedure does have two sides, a good side and not very good side. When you do the scan, even if you don't have lung cancer, it is very likely that you will find a small spot called lung nodule, which a lot of people do have, and it's more than 90% benign. But that will mandate further workup to follow these nodules to make sure that they are not growing.
Okay.
And there's no procedure. So that sometimes can create a little bit of level of anxiety. Oh my God, they found a spot on my lung. So
Sure,
so
absolutely.
people need to be aware of that as well.
So we've talked about smoking being a risk factor. Well, in today's world, especially with the younger generation, but older generation as well, more and more, we're seeing vaping.
Yeah.
So where does that fall into this?
That's a great question. Vaping is conceived by the younger generation, teenagers, as a safe alternative to tobacco use. I think the reasonable answer to that is we don't know. I mean, people were smoking cigarettes for a long, long time, not aware that lung cancer is going to start showing and start to be a problem. Vaping has not been there for a long time. We don't know the long-term consequences of that. That's number one. Number two, the vape also do have chemicals. People need to understand that. There is a lot of, the manufacturer will add certain flavors that like coconut. Some will add vitamin E, for example, and those are toxic to the alveoli. And the alveoli are the functional unit of the lung that gives your body oxygen and extract carbon dioxide. We have seen a lot of people, young people, getting into the hospital and going into mechanical ventilation because of vaping.
Oh, wow.
In fact, the medical dictionary now has this new term called e-valley or e-cigarette vaping associated lung injury. So it is an issue. It's not safe. Please be aware of that. I cannot answer the risk for lung cancer because it is too soon.
Sure.
But I can tell you it's not 100% safe.
So just curious. So if someone comes to you and says, I've been smoking for 20 years, I want to stop, but I'm having a hard time. I feel like what I hear more often is that people say to them, oh, well, just switch to vaping because that's better for you. It's not good for you, but better for you than smoking. And maybe that'll help you wean off, right? Wean off
Yeah.
smoking. Is that something you often recommend or?
To be honest with you, all pulmonologists did that in the beginning before we see this, group of young people getting admitted to the hospital with
Sure.
all these lung injuries. So I'm very hesitant to, um, you know, say that recommendation.
Yep. Okay, that
There's
makes
still a
sense.
lot of research, excuse me, that needs to be done to help people, quit smoking safely
Yep.
and in a safer way than e-cigarette.
Yeah. That makes absolute sense. Well, another question that that I have, and we have, St. Joe's has recently, relatively recently, specialists, and obviously you focus quite a bit on lung cancer screenings, but when you do these screenings, how do you do them? I know there's a tool you use that can help screen and identify stages of lung cancer. Can you tell us more about what that is?
So lung cancer screening basically is a CAT scan of the chest. It's low radiation to minimize the risk of radiation exposure because we are not looking into specific structure into the chest other than the lung tissue. So that scan will give us a great idea about how the lungs look like. Is there nodules? Are these nodules worrisome? Are they round? Are they irregular? Where are they located in the lung? Is it one? Is it multiple? And based on those findings, along with risk factors or the risk factors that the patient have, then we determine the next step. Most of the time, as I said, 90% or more of these nodules are benign.
Yep.
Sometimes, though, on lung cancer screening, we do discover lung cancer. That's the reason we are doing the scan. And the studies have shown that when you discover the lung cancer early, you have a way higher chance of surviving that compared to when you find it later.
Yeah.
So that is the main reason for lung cancer screening. You follow with your doctor. He directs you about the next step. The next step may be another scan in 1 year, which is most of the cases. The next step may be go and do bronchoscopy and get a biopsy, or go to the surgeon and take it out.
Now, the bronchoscopy, you and I have chatted before, is you mentioned the EBUS
Yeah.
bronchoscopy. Is that what that part is? Is that next step?
Well, I mean, the next step is basically if you have a lung nodule that was discovered on the lung cancer screening,
Yep.
and you did determine that this lung nodule either suspicious, the way it looks, like we call it speculated, means that it's irregular, or it's growing in somebody with risk factors, then the a biopsy is needed, and the biopsy can be done into several ways according to where it is located in terms of the CAT scan. Is it close to the periphery of the lung? Is it close to the medial aspect of the lung? So we can either do biopsy by sending the patient to interventional radiologist who can get a biopsy from outside, or we can go with a scope that has a camera at the end of it called bronchoscope, like colonoscope or endoscope, and go into the bronchial tree and direct our scope under image guidance like fluoroscopy or, excuse me, advanced bronchoscopy like navigation bronchoscopy, where it kind of guide the catheter into the exact location of the nodule and take biopsies from that nodule to determine if this is cancer, what we need to do. The EBUS or endobronchial ultrasound will help us in two ways. Number one, there is a endobronchial ultrasound that you can see the lymph nodes in the chest, which is very, very important and very helpful because that will tell us what stage is that lung cancer. Are these lymph nodes involved with any process like lung cancer? And it's a procedure that takes about 1 hour. The patient will be under general anesthesia, completely comfortable.
Right.
We go in with the scope, we take several biopsies we ask the patient to stop any blood thinners that he's taken. And then the result comes after 2 to 3 business days. We call the patient, let him know about the result, and tell him about the next step required.
Got it. Now there's my next question. How long does it usually take to get that answer? And it sounds like it's just a couple days.
Yeah, very expeditious. We have excellent pathology department. We collaborate with them. We send them the specimen. We alert them that we did this biopsy. Can you text me when you take a look at the slides?
Yeah.
In most of the cases, I would say 2 to 3 business days is adequate to get an answer.
And it sounds like it's not painful because you're under anesthesia. Any risk factors to consider with EBUS?
Absolutely. I mean, any procedure can carry risk. There is no 100% safe procedure with the EBUS. There are risk factors related to the general anesthesia, since the patient will be under anesthesia, like low blood pressure, low oxygenation. There are other risk factors like bleeding, since we are getting biopsies. But those are usually minimal, less than, I would say, 2%. And as I said, we ask the patient to stop any blood thinners before the procedure at a certain days, depending on what blood thinner he's taking.
Okay. So just to quickly recap, if a patient, let's just assume they fall into the risk category, they're a smoker, they're over the age of 55, or they have a family history, and they want to get screened. Best process, call InCare directly or go through primary care?
Well, the best process would be to go through their primary care physician. And, primary care physician can easily order the lung cancer screening. If there is some findings that are of concern, then the primary care physician can refer the patient to InCare Pulmonary, and we can help out and keep direct communication with the primary care physician about the next steps.
And just as a reminder for our patients, and correct me if I'm wrong, but if our patients require a bronchoscopy and they go through InCare, it happens here on site, correct?
Correct.
The whole process.
Correct.
Great. So we have just a couple minutes left, and we've talked a lot about lung cancer, but are there other things that InCare treats, other ailments, other things that you're concerned about just in your day-to-day work that you want our general public, our audience to know about?
Sure. I mean, we see all the pulmonary disorders like asthma patients. We have a lot of asthma population. We do apply very advanced care for asthma patients, including starting biologic treatment to control their asthma symptoms better than just the inhaler. If the inhaler is not controlling their symptoms, those biologic treatment can involve monthly injection under the skin that the patient can give themselves. We also treat a very large population of COPD patient with emphysema, and also we apply advanced technology and advanced treatment for that. We are hoping at some point to introduce an interventional program where we can do what we call endoscopic lung volume reduction with a scope. It's a work in progress. We also treat patients with very common condition like sleep apnea. My colleagues are specialized in that condition, and they do excellent job at that. There are patients also who do have what we call pleural disease or pleural effusion, which is collection of fluid around the lung that makes them short of breath. We also have intervention to help them out as well. So we do the whole spectrum of pulmonary and critical care.
Well, that's fantastic. Well, now we are, I think we're officially done with today's broadcast. So I want to thank Dr. Akash for joining us today. I think that was some great information for our audience members, for our patients, to better understand, lung cancer, the importance of screenings, and also many of the other services that your organization provides right here at St. Joe's. So thank you again for joining us, and we look forward to seeing you all next time. Thanks, everybody.